Good morning, friends. Good morning, colleagues. It is my great pleasure to welcome you to this FIP webinar, Reframing Pharmacy's Role in Hypertension Prevention and Care. It is not by accident that we are having this webinar on today, the 29th of September, because today is World Heart Day. So I want to wish everybody a healthy heart, and I want to thank you for the enthusiasm that we have from pharmacists and pharmaceutical scientists around the world, because we have over 1,000 registrations for today's webinar, which I know is going to be fascinating. May I start by introducing myself? My name is Daragh Connolly, and I am the FIP Board of Pharmaceutical Practice Chair. But much more importantly than that, I am a practicing community pharmacist. So at these times when we have our FIP webinars, I love to see the names and welcomes and greetings, salutations that are coming from people who share our love for pharmaceutical care. And I see the places coming up and the names coming up in the chat box. So please use the chat box and introduce yourself. And already I can see that we have colleagues and friends from Mauritius, the Philippines, Rwanda, India, and Ghana. We're really lucky today to have fantastic professionals, scientists, practitioners to give us a really good understanding of what health on our hearts is all about. But before we get to that stage, I'd just like to make a few housekeeping announcements. And it's important to know that this, for your reference afterwards, this webinar is being recorded and live streamed via YouTube, and that this recording will be available on our website, which is www.events.fip.org. And we would be more than delighted if you would ask questions and that you would do that using the question box provided. We always welcome and in fact encourage your feedback to know how we are doing with these webinars, what we can do better, or if there are webinars that you think that topics that we should be covering that we haven't. And I think most importantly, we can only be the representative federation that we are by having a strong membership. If you are not already a member of FIP, I would ask you to become a member of FIP. And you can do so by finding the link at the website, again, at www.fip.org, membership registration. In order to get this really brilliant webinar to as many people as possible, know that there is a translation feature on Zoom. So you can turn on your captions, enable the translation toggle, and choose your preferred language under My Caption Language. And you can follow along with the live translated captions. I want to note and thank an acknowledgement to say that this online event and Hypertension Pharmacy Toolkit are supported through unconditional funding from AstraZeneca. We have a brilliant lineup today. So Andrea Vassalotti is with us, and she's the Senior Director of Partnership and Programs at the World Heart Federation based in Switzerland. Professor Ross Giacchi is Professor of Medicine and the Director of the Epicor Center, the Faculty of Medicine and Dentistry, the University of Alberta in Canada. Professor Nesligul Özdemir Aydoğan is the Assistant Professor at the Gazi University in Turkey. And we're also ably assisted by Dr. Ines Nunes de Cunha, who's the Practice Development and Transformation Manager FIP in the Netherlands. And she is being helped today by Gamze Noor Songer, who's an intern at FIP based in the Netherlands. We have today's program, which I think will be self-explanatory as we get to it. So we'll move along to the next slide because we'll be introducing each of the topics at the time. What is really important with this is we all each have our own individual learning objectives, but the broad learning objectives that we have today are to understand the global burden of hypertension and the need for collaborative, multidisciplinary action. We want to recognize the pharmacist's role in improving treatment and adherence and continuity of care. And it's really vital to stress that that doesn't really matter what area of practice that pharmacist has as their focus in their working life. We want to identify opportunities for pharmacists to prevent, detect, and manage hypertension through people-centered care. We want to be able to show that we can apply evidence-based hypertension guidelines in pharmacy practice and explore the new FIP Hypertension Pharmacy Toolkit and apply its tools to enhance pharmacy practice. So without further ado, I'm delighted to introduce Andrea Vassilotti, and the topic of her conversation today is addressing the global burden of hypertension and promoting adherence through collaborative care. Andrea, over to you and a very warm welcome.
Thank you. Thank you so much, Dr. Connolly, and to the International Federation of Pharmacies for organizing this important discussion. Thank you. Can proceed to the next slide. So first of all, I'd like to frame the global prevalence of hypertension. I'd like to also recognize Professor Pankaj Gupta from the European Society of Hypertension, and also my colleague Shreya Shrikanda, who've helped to provide some of the information that I will share with you. So hypertension is one of the most common risk factors for health overall, and it affects about a third of the population, slightly more prevalent in men than in women. But what's very important, if we take a look at the heat map here on the top part of this slide, the proportion of prevalence will be even higher than 1/3 in many countries around the world. We can see that particularly Latin America, Sub-Saharan Africa, Eastern Europe, particularly Russia, very, very high levels of prevalence of hypertension. And as we know, can be quite easy to measure, to diagnose. So it's really a risk factor that we must insist on keeping under control. And as we know, there are smaller proportions of people taking treatment for hypertension than there should be. And also, I would say too large number of people who are today untreated. So, and we could see also some sex differences, which are quite interesting. Women, one might seem to believe are either better diagnosed or maybe they adhere better to treatments. And if we could click down once more on this slide, hypertension affects 1.4 billion people worldwide. So this is really so important. Today, World Heart Day, we really need to be measuring our hypertension, and everyone should know the numbers. So very, very important. Next. So a few words about the World Heart Federation, the organization with which I represent. We're a Swiss-registered nonprofit, and we're an umbrella organization that represents the global cardiovascular community. So we have typically members from all over the world who often have a national or regional focus, and they come to us for best practices, but also to be connected with other organizations, and a lot of our work and frameworks which support them in providing cardiovascular health for all. So we're the only global cardiovascular organization that has an official relationship, a non-state actor status with the World Health Organization, which is also why we are based in Geneva. Our membership, which is only made up of nonprofit groups, are about over 240, and we're in 120 countries around the world. And in the year 2000, our then president created the World Heart Day campaign as a way of making cardiovascular disease visible. So we're now celebrating the 25 years, and it's more important than ever because heart disease, the symptoms of heart disease are often invisible, which makes it hard for people to take seriously. This year, on the 27th of March, the World Heart Federation came together with a number of organizations, including the International Federation of Pharmacies, to celebrate the first World Adherence Day, which took place on the 27th of March, and really shows that this is an area of health which we need to focus on a lot more in the future. Next. During the First World Adherence Day, we're able to create a spotlight on an issue which people really knew little about. You know, the media didn't know why does adherence to, say, doctors' advice, both treatments and maybe recommendations to lose weight, get more physically active, stopping smoking, they didn't really realize why this was important. And what was great with our task force, we were able to provide local level data and evidence. For example, in Brazil, the Folha de São Paulo was able to print articles because we specifically addressed what was going on in Brazil. And that, of course, that member network in nearly 120 countries around the world meant that we had local experts. And for example, in India, we were able to provide them with an expert who could address the local perspective on adherence. So really super important. And we reached nearly 540 million people through all of these media activity and articles. So really very, very impressive. And we had 15 groups behind it who were promoting this message to their constituencies. And of course, pharmacies and pharmacists are a very, very important point of contact for patients. Next. So one of the big issues is that adherence is really not a topic in the patient healthcare provider conversation. There was a survey across Europe of nearly 3,200 healthcare professionals, and it resulted that only about half of them actually ask about adherence. So as a result, including empowering patients and talking to patients, we really need to support healthcare professionals in starting the conversation with patients. Many have told us that during their years of study, this was never brought up. They didn't know how to start the conversation. So improving that needs to be a priority. And on the next slide, I will show you a little bit about what we did. So first of all, on the left hand of this slide is the World Adherence Day logo, which, as you see, is part of it is a dial, and that dial is very similar to maybe a pillbox, showing how it can be complex to stay on schedule, particularly when you have numerous medications. And this brochure is really is one of the tools that we created to support healthcare professionals and suggest some of the questions that they can ask to really dive into adherence with their patients. Next. And another very interesting data point which studied non-adherence to antihypertensives by age group, showed that number one, there's a very steep drop off from the moment of first prescription to about 3-4 months later. And this is really a great opportunity for pharmacists to keep the conversation going, see if someone has recently been prescribed medication, they may need some additional support to stay on track. But another very important point is age. The younger you are, the less adherent you tend to be. And that goes back to, I think, the invisible nature of cardiovascular disease and hypertension. People don't feel they're really constricted in their everyday activities, so may not really see the need to stay on track. And that was why and of course, another aspect is that, and it's not demonstrated on this chart, but very important, is that the more medications patients are prescribed, particularly if they have more than 5 medications to take, the lower their levels of adherence will be. Next. So part of the campaign was creating this "Don't Miss a Moment" hashtag and battle cry, really, because patients need to see this, answer the question, what's in it for me? Why should I take these medications that, I don't really feel, maybe I'm not convinced about or don't feel are necessary. And we created something called a "Don't Miss a Moment" wall, the memory wall, where people will say, what is it that you want to be around for? To spend time with your children, to see maybe a son or daughter get married, or to take that exotic vacation you've always dreamed about. And a very simple call to action, which is really a very logical flow: better adherence, better control, better outcomes. So we're really, by not keeping on medication and therapeutic schedules, people are really damaging their health. And on the left-hand side, you see this adherence declaration. Where really, there is a declaration you can sign on the web page, and we're encouraging people to join the movement. Next. Of course, all of these activities were accompanied by a social media campaign, which generated 70 million total impressions, which was pretty impressive. So a lot of our member groups obviously leaned in on this messaging. We had also T-shirts or logos for T-shirts that could be printed locally, but a lot of provocative messaging, such as "there's no one size fits all for adherence." And this was really great to be able to address this. And I see some of the questions coming in. I would like to mention that there is a web page. So if you type in World Adherence Day to your browser, you will come to our web page, and you will see not only the memory wall, but all of the brochures and toolkits that I've mentioned. Next. So the role of pharmacists in a multi-stakeholder patient partnership with patients. On the left-hand side, you see adherence is a shared partnership. So it's really a continuum. Obviously, patients are involved with many healthcare professionals and others, and each one singly probably doesn't have a lot of time to dedicate. We also talk to them in different ways. I'm very convinced that nurses, and particularly pharmacists, have far more proximity, and sometimes can have, I would say, maybe more productive and more practical conversations with the patients. So what I'd like to say is that the positive impact of pharmacists on adherence is vastly recognized. I mean, this has been clearly demonstrated in the guidelines on hypertension that the European Society of Cardiology and the European Society of Hypertension have recently published. And team-based care models are the way of the future. There's no way that we can reach everyone with problems as big as hypertension alone, so we're going to need the strength of all players. And also there's an expansion of the role of pharmacists, and we're going from a primary to really chronic disease management. And in the UK, very soon, in just a few months from now, pharmacists will be able to prescribe medication. Next. Patients have mentioned to us that they would like to see more, for example, single pill combinations, smarter packaging, and also patient leaflets, more information about the subject. And World Heart Federation recently produced a roadmap on single pill combination therapies. Very important that we should support these because they do support greater access and adherence to cardiovascular therapies. Next. And really, we're going toward a new perception of adherence. As I mentioned, we have the better adherence is just equal to better outcomes. Improved adherence will mean significant cost saving for health systems. So there are costs in there that are just not saving lives and not improving lives. And that's really what we want. And finally, is non-adherence a risk factor, just like smoking or hypertension? Is it something that's damaging to health? And maybe it's something that we should really spend time on measuring. So thank you so much, and very happy to listen to the next presentations.
Andrea, that was a really, really thoughtful and very thought-provoking presentation. I really like the way that you focused on a team-based outlook. And I think what's really important as well is my two big takeaway messages there are to recognize that not one size fits all. I think we know that. And I think really what that means is, and I really like the theme that's coming through there, this is about person-focused care. So thank you for an excellent presentation. Ladies and gentlemen, colleagues, I'm delighted to see that there are questions coming through. Where I see it on my screen is in the top right-hand corner. There's a Q&A button. So please use that rather than the chat, because we don't want to miss any of the really good questions I know that people have. We will be able then to have a look at all of those questions in the round at the end, time allowing. Our next contribution comes from Professor Nezlegul Özdemir Aydoğan, and she's the assistant professor at the Gazi University in Turkey. Her talk today is about expanding pharmacy's role in hypertension and prevention and early management. You're very welcome, Professor.
Thank you very much for the introduction, Dr. Connolly. I would like to thank International Pharmaceutical Federation for organizing such an important event and inviting me as a speaker. It's a privilege to share our insights on a topic that is central to public health, the role of pharmacists in hypertension prevention and early management. In this presentation, I will briefly highlight what we know about pharmacists' role in hypertension. Then I will discuss how pharmacists can contribute to the prevention and the early detection of hypertension. I will also touch on their contributions through community engagement and patient education. And finally, I will point out opportunities for service development and integration with public health initiatives. As you know, arterial hypertension is the leading modifiable risk factor for cardiovascular morbidity and mortality. In the United States and in some European countries, pharmacist patient-centered care is well established. And we know that pharmacists have a proven role in managing cardiovascular disease. And the benefits of pharmacists provided hypertension care has been compared by recent studies. And it is clear that guidelines recommend blood pressure checks for every adult more than 40 years. Pharmacists have a wide range of interventions in hypertension management. disease state education, patient counseling, blood pressure measurement and monitoring, adherence monitoring, medication therapy management are maybe the most important interventions. I want to share a study, a meta-analysis about pharmacists' role in hypertension management. This is a meta-analysis and it was included 95 randomized controlled trials. And when we look at the study design, in the quarter of the studies, interventions were directly pharmacist-led, and in the remainder studies, the interventions were provided by collaboration with other providers. And when we look at the type of interventions, the most related interventions are patient education, feedback to providers, and patient reminders. And when we look at the outcomes, there is a significant increase in blood pressure. Pharmacist's role in hypertension prevention is as important as pharmacist's role in hypertension management. And to provide hypertension prevention, pharmacists have a lot of interventions. One of them is lifestyle counseling. With this counseling, pharmacists can prevent hypertension. These counselings can be related to nutrition, weight control, exercise, smoking cessation, or reduced alcohol intake. And the other intervention is risk factor management. And I think it is the essential intervention for prevention of hypertension, because screening for obesity, diabetes, and dyslipidemia, and referring to these patients to physicians essential for prevention of hypertension. The other intervention is medication review. And we know that there are a lot of drugs that may increase blood pressure, and identifying these drugs, I think, will prevent hypertension. The other intervention is health promotion, and pharmacists can organize community-based education programs and increase awareness about hypertension risk. To be able to detect something, you should screen or measure it. For hypertension, this is blood pressure screening. By regular blood pressure checks in community pharmacies, pharmacists can identify undiagnosed or pre-hypertensive individuals. After identifying these patients with elevated readings, pharmacists can refer these patients to physicians. And pharmacists' role does not end at here. They should also track patients at risk and support adherence to follow-up visits. And to make this, they should use digital tools, apps for self-monitoring guidance and for home blood pressure monitoring education. I would like to share a study about pharmacist-led hypertension preventive and detection service. This was a study designed as an exploratory pre- and post-study, and it was conducted in 3 community pharmacies. Individuals at risk were identified by medicine counter assistance, and blood pressure were measured. Individuals with high blood pressure levels were referred to pharmacists for further assessment, and pharmacists referred these patients to physicians when needed. And individuals' awareness and lifestyle change assessed at baseline and after 6 months. Totally 170 individuals were screened, and 25% of them had pre-hypertension, and other 25% have stage 1, and 8% had stage 2 hypertension. The risk factors were lack of exercise, poor diet, and obesity. And with the intervention of pharmacists, patients reach lifestyle change such as weight loss and alcohol reduction. But The most important result of this study is nearly 30% of referrals diagnosed with hypertension. And it is clear that pharmacists' interventions are effective in early detection and prevention of hypertension. This is another study which conducted in Turkey. This study's aim was to assess impact of pharmacist-led blood pressure screening and referral for high-risk individuals. This study was a prospective pilot study and carried out in a community pharmacy. A clinical pharmacist measured blood pressure at baseline and follow-up, and patients, individuals with high blood pressure levels referred to physician. 62 individuals were identified as with high blood pressure, and among them, 23 were referred to physician. Among referred individuals, more than half diagnosed with hypertension, and 35% of them were pre-hypertensive. And the conclusion is very clear. Pharmacist-led screening improved detection and referral of high-risk individuals. And the last study is, again, it's a meta-analysis, and it is about healthcare professional-led interventions on lifestyle modifications for hypertension patients. It was included 34 randomized controlled trials and with more than 22,000 patients. The interventions were lifestyle modification led by physicians, nurses, and pharmacists. And a significant decrease, the results showed that there was a significant decrease in blood pressure levels. Blood pressure control was achieved in 56% of patients in intervention group compared to 44% of patients in usual care group. And this study showed that healthcare professional-led interventions significantly improved blood pressure. Community engagement and patient education is also important for prevention and early detection of hypertension. Pharmacists can contribute community engagement with different ways. They are accessible healthcare providers, and they are positioned at the front line, so they can interact with patients frequently. They can provide community screenings not only in pharmacies, but also in different places such as workplaces, schools, and community centers. Also, pharmacists can collaborate with local health authorities and patient associations to increase awareness of people related to hypertension. And the patient education is also really important for prevention of hypertension. Through individual counseling, the use of educational materials and guidance for home monitoring, and strengthening the empowerment of patients' health literacy, pharmacists can contribute to prevention of hypertension. Opportunities for service development and integration with public health initiatives. To understand this topic, we need to answer this question. What do we need to expand pharmacists' roles in hypertension care? We need enhanced clinical services such as medication therapy management, blood pressure monitoring, and adherence clinics in pharmacies. Also, pharmacists should use technology, should use digital health tools such as mobile apps, telepharmacy, remote monitoring to expand service. Also, strong interdisciplinary collaboration with pharmacists, physicians, and nurses is essential for comprehensive hypertension management. Advanced training and specialization in cardiovascular health is again essential to expand scope of pharmacist practice. What can we do to link pharmacy practice with public health programs? We can provide community-based screenings. Also, pharmacists can collaborate with ministries of health for preventive campaigns such as salt reduction, smoking cessation, and obesity prevention. Again, pharmacists can can increase awareness about health literacy. The other topic is policy integration. Maybe this policy integration can be more difficult than other topics because it includes a lot of participants. I want to share something about International Pharmaceutical Federation's global initiatives. One of them is education and capacity building by learning models for chronic disease management. And hypertension is one of these diseases. International Pharmaceutical Federation also support active involvement of pharmacists in public health campaigns such as World Hypertension Day and other awareness initiatives. Also, it collaborates with World Health Organization to release guidelines which highlighting pharmacists' roles in blood pressure screening, early detection, and patient education. International Pharmaceutical Federation's contributions have some opportunities. These are community engagement, patient support, conducting research and pilot projects. And the future vision is integration of pharmacists as key professionals in chronic disease management within primary care. Finally, I want to share something about May Measurement Month. It is a global blood pressure screening awareness campaign, and it was launched in 2017 by the International Society of Hypertension. Its aim was to raise awareness of hypertension and importance of regular blood pressure checks. It provides lifestyle, diet advice and guidance for those with high blood pressure. And it has a global impact because data used to motivate governments to improve blood pressure screening. And it is the largest free blood pressure screening program. It includes more than 100 countries. And it is held annually between May and July, aligned with World Hypertension Day. In this slide, you can see the participating countries, and Turkey is one of these countries also. And I want to share a new development in our country. This is a vital signs entry from pharmacies and physician public health management platform integration. With this system introduced the vital signs and body measurements section, and pharmacists can now record patient measurements data into the system, and these data are automatically visible to physicians. And I think this step is an important step to for integration of pharmacies as official data providers in the blood pressure measurement and monitoring cycle. However, I would like to emphasize that this practice shouldn't impose a workload on pharmacists and should be regulated in a way that protects their professional rights. To conclude, pharmacists make a real difference, and lifestyle and education are powerful tools. Community engagement is essential for prevention and early detection of hypertension. Integration with public health initiative is the way forward. And finally, maybe the most important message is there is a really critical research gap in this area. While pharmacist's role is proven in hypertension management, well-designed national and international studies should be conducted, urgently needed for prevention and early detection of hypertension. This is essential for showing pharmacist effect on prevention and early detection of hypertension. I want to thank everyone for our audience.
Estegil, that was an amazing presentation. Thank you very much. I am really blown away by the data that you've collected from your home country, but also from other countries around the world. And I see a message coming across from Ross to say that we should have a look at forming a coalition of pharmacists who are measuring in May, because it is all about the data. You had an excellent sum up But one word that really struck out to me was empowerment. And I think not only is it that we need to empower people who are living with hypertension, I think we also need to be able to empower pharmacists to do their job and to look after people as well they can. And I think ultimately that is going to be based around the research. So congratulations on the research that you've done, and thank you for sharing that with us.
Thank you.
Our next contribution is titled Implementing Evidence-Based Hypertension Guidelines in Pharmacy Practice, and it is presented to us by Professor Ross Suzuki, who's the Professor of Medicine and Cardiology, and he's the Director of the Epicor Centre at the Faculty of Medicine and Dentistry, the University of Alberta in Canada. Ross, you are most welcome, and thank you for sharing your expertise with us today.
Thanks so much. Happy to be here. Thanks so much for inviting me. Okay, so can you start up my slides? All right, thanks very much. So I would like to start by amplifying what Dr. Nezago said, and that I'm going to put it a different way. I think there's more evidence for pharmacists and hypertension than anything else for pharmacists, or drugs for that matter. How many things do you know of where there are 95 randomized controlled trials? Not too many, I would say. And as you know, a systematic review done properly is the highest level of evidence. So I think you can all be pretty proud that we have the highest level of evidence for pharmacist care versus usual care in hypertension, encompassing over 31,000 subjects. And the interventions here are mostly educational and feedback and reminders. This doesn't incorporate pharmacist prescribing, which shows an even larger effect. And if any of you are interested, we can address that later on. So I don't seem to have control over the slides here. There we go. Okay, so I was asked to speak on the topic of guidelines, and as it so happens, we've just released some new guidelines. And so I want to speak to you a little bit about what those guidelines are, because I think they're very, very encouraging for pharmacists. So we know that over 90% of hypertension is managed in primary care. Secondly, pharmacists are primary care providers. I know that we often don't get included in those discussions, but pharmacists, by definition, primary care is first point of contact with the medical system. And so pharmacists are actually, I would venture to say, very often the first point of contact. So recognizing that, we decided that we would do two sets of guidelines. One is for primary care, which would encompass more than 90% of patients, and then some specialist guidelines. So I'm going to talk about the primary care guidelines. Now, this is a balance between what is pragmatic and what is evidence-based. Anyone of you that has seen our guidelines before, it was very evidence-based, but it was also this thick and really difficult to go through. And so how do you make that balance? So we base this upon the WHO PAHO HEARTS program, which is quite simple and actually has good evidence for it in itself, with a lot of countries going over to about 90% control just using those simple algorithms. Importantly, when we put this together, it was designed for and with primary care providers. That means, and that's the broader definition of primary care. It's family physicians or GPs, but it's also pharmacists. We had a number of pharmacists on the team and a nurse as well. And so, if you want an audience to pay attention, you invite the audience, and so that's what we've done. Simultaneously, we also invited 4 patient partners to be part of our guidelines as well. And one of the things that they provided input into was a simultaneous patient guidelines that are part of our guidelines as well. If you're interested to look at this, you can scan the QR code here. The other thing I think that was an important message, and I was really, really pushing for this, is you can see the main publication here on the left-hand side of the slide, and it was published in sort of traditional places like the Canadian Medical Association Journal, which is the big journal in Canada, but also it was published in Canadian Family Physician, and at the same time, the Canadian Pharmacist Journal. Identical publications simultaneously published, in fact, at 11 o'clock Eastern Time on May 26th. So the message there is that these guidelines are for all healthcare professionals that are involved in primary care. So I think that's important as well. I'm going to go very quickly through the recommendations in this, and I think you'll see why I'm doing this. So there's only 9 recommendations in the entire guideline. And I'm not even going to go through all of them. But first of all, it all starts with assessment. And the previous speaker mentioned the importance of that. So we say blood pressure measurement done properly, because most of the times it isn't done properly, using a standardized method and a validated automated device. And all of you know that the devices that you can buy online, a lot of them are not valid. There's no evidence of validation. So that's really important. We also highly recommend out-of-office blood pressure assessment to confirm the diagnosis of hypertension. Hypertension measured or blood pressure measured in an office is probably not all that accurate. And when you layer onto that the poor technique demonstrated by most primary care clinicians, then you can see why. So out-of-office blood pressure measurement is important. We recommend home blood pressure monitoring, and there's a big role for pharmacists there. And so here's the other thing. We've made it simple. There's only one number you need to know: 130. That's the number you need to know. The definition of hypertension under our new guidelines is 130. We don't even that much care about the diastolic, but we did put a number there. It's 130. Okay. So the diagnosis is vastly simplified, and for good reason. So if you want to look at the diagnostic tree, and we have actually said that there's no reason that a pharmacist cannot make this diagnosis. So in patients that you're screening, you do the equivalent of an office blood pressure assessment, and of course you're doing it properly. And if it's over 130, that's a high degree of suspicion of hypertension. And then you do some out-of-office measurement, which means sending somebody home with a home blood pressure monitor. We recommend a 7-day protocol where they take their blood pressure morning and evening for 7 days. We throw out the first day because the first day is always, for some reason, high, to rule out white coat hypertension. And if they come back consistently above 130, that's hypertension. That does not take any special skills to identify. It's hypertension. Okay. Let's move on to treatment. So healthy lifestyle, yes, absolutely. I'm not going to talk about that because of time, but it is obviously still really important. And that is sodium reduction, higher potassium diet, and exercise, and weight loss. Pharmacotherapy. Okay, so pharmacotherapy for everybody that's above 140, and even those between 130 and 140 that have high cardiovascular risk. So there is basically the threshold is also 130. 130 to treat, 130 for the target, 130 for the diagnosis. Okay, so we intentionally simplified this so that the only number you really need to know is 130. Okay, so the target is 130. There's that gray area between 130 and 140 where you might just try lifestyle, but the reality is you all know they're going to be needing pharmacotherapy. Here's another thing where we've simplified things. We now recommend low-dose combination therapy as a single pill combination as the initial treatment. So, and we say basically it should be an ACE or an ARB with a thiazide, or possibly a long-acting calcium channel blocker like amlodipine. Okay, so we recommend that, and I'll show you in the algorithm how that works. If that doesn't work, you step that up with the combination therapy, add a long-acting dihydropyridine calcium channel blocker, and I'll show you that in the algorithm next. So the implementation tool that we developed is, again, super simple. Again, the target less than 130. Then you start the lifestyle changes, and then you head to pharmacotherapy. You can see here in the gray box. So we recommend, we actually, the feedback that we got from primary care providers was just tell us what to do. So we did that. And so we said, we're actually recommending a half tablet of the combination of irbesartan hydrochlorothiazide, 325, which means that the starting dose is 150 and 12.5 of the hydrochlorothiazide component. So a half tablet once a day. And then you assess every 1 to 3 months until the blood pressure is at target. So step 1, half tablet. Step 2, full tablet. Step 3, add a bit of amlodipine. Step 4, if you have to get to it, then it's starting to look like resistant hypertension. And so we recommend that you either refer to a hypertension clinic, or if you're comfortable with it and can actually get your hands on spironolactone because of the shortages right now, you would add spironolactone, and that will take care of almost well over 90% of patients. So we've really simplified it, as you can see, and we are just now getting into the uptake of this. So anyways, if any of you are interested, I encourage you to look at this. So what does this mean? Well, first of all, I thought it was really important. It was recognition of pharmacists as primary care providers who have an important role in hypertension detection and management. This is a couple of quotes taken from various people. The International Society of Hypertension has been saying, look, current methods of managing hypertension are inadequate. So doing the same thing and expecting better results is crazy. The definition of crazy, actually. So we need everyone to help. And Dr. Taskeen Khan, when she was at the WHO, recommended, or the WHO recommendations number 8 says treatment can be provided by non-physician professionals. And the International Society of Hypertension, which is the hypertension organization of organizations, also stated that specialist care is not enough, and that primary care clinic, and that means primary care physician clinic based, is not sufficient either. So that opens the door for pharmacists. And the new Hypertension Canada primary care guidelines are actually quite explicit about the pharmacist's role, and you can see that the highlighted statement there from the Hypertension Canada guidelines. All right, and this is not new. The Hypertension Canada has been supportive of the pharmacist role for actually a long time. And in fact, here's this was written by the president of Hypertension Canada at the time in 2019. And Dr. Khan had actually said, supported a call to action to implement prescribing authority to pharmacists for hypertension management. A lot of Canadian pharmacists already can prescribe for hypertension, but not all, because we have different jurisdictions. Okay, so where are we going with this? I want to just show you what our approach is taking right now. So we already have really good evidence for pharmacist care. There's no question, like 95 randomized controlled trials. What we need to do is implement it. And this is where efforts like what FIP is doing and what you're going to hear about next is so incredibly important. What we're doing in Canada, in the province of Alberta, is we have developed these electronic tools called care pathways, and they follow. It's a bunch of different chronic diseases, COPD and cardiovascular risk reduction, etc. And they all follow this pattern where you can't treat a disease if you can't find it. So, and we never talk about case finding. So case finding is really important. It all centers around assessment of the patient. So the guidelines provide you with what needs to be assessed. So we integrate that from national guidelines. There's always, depending on your scope of practice, there's always going to be situations of what we would call in English red flags, where somebody needs referral for to emerge or to a physician because of something out of scope or a secondary cause. And so we highlight those. Then there's the treatment. And again, that depends on your scope of practice. But in our case, the pharmacists are prescribing the therapy. And then this is another thing we don't do very well, and that is structured follow-up. So guidelines provide the structure for what follow-up should be. And all along, what we're integrating is shared decision-making with patients as well. So all of our new care pathways are doing this, and we're evaluating them in randomized controlled trials. I'm just going to show you the one example, and this is called PROACT, and this is an ongoing study. We basically, this is probably not the place where you should start, but PROACT is cardiovascular risk reduction. And so it incorporates hypertension, diabetes, dyslipidemia, and tobacco cessation. It's being tested in a randomized controlled trial in community pharmacies in the province of Alberta. We're enrolling 1,000 participants. Here is the reference for the design of this study. And again, it follows the same pattern as the previous slide. Case finding, assessment. Part of that assessment is cardiovascular risk calculation, for which we have a tool, and then it's evidence-based and guidelines-based treatment and developing the plan. And this is where we participate in shared decision-making with the patients and structured follow-up to get to cardiovascular risk reduction targets. So if any of you are interested, you can see the reference that is right there. So to conclude, yeah, there's clearly, you're all here, so you know this. There's a very clear and urgent need to improve hypertension management. There is really, 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 really robust evidence for pharmacists. I would say, and we can address this in the question and answer period if you want. The biggest barrier is actually us not pushing this forward strongly enough. If you think about it, where there's such good evidence and we're not doing it, there's something wrong. Happy to discuss that though. It is facilitated by simple new guidelines, support from all the hypertension organizations I know, and now the development of implementation tools. So at this point, we really need to get on and start doing this. So glad that you're all here and we can talk about that. So thank you so much for your attention, and happy to field any questions.
Ross, that was amazing. Thank you very much. Thank you for your ever-present enthusiasm and your ever-present expertise. I always get a real sleeves rolled up vibe from you, Ross, that you're a pragmatic and a practical kind of guy, and I think that's what we have to take on board with this. Look, let's face facts. This isn't a really hard thing to do in a community pharmacy or in a hospital setting or wherever people might work in a clinic, but we have to allow ourselves the time and the space to do it. That will all come from a confidence that we get from knowing that we can do it, from knowing that we have robust evidence by experts around the world, and we've just heard from 3 of you to do it. But I think FIP's role in this is to be able to drive that on, is to be able to show people how to do it and to use that focused model that we have to give people the confidence to go forward. So Ross, thanks a million for that brilliant contribution from you. I'd also like to thank Andrea. She's doing a really good job of answering as many questions as she can inside in the Q&A. If that's the place for the questions, and it also means that we won't miss any if you get them in there, but it also means that they'll be recorded within there so other colleagues can benefit from it. There's a really high participation today. I'm really, really thrilled with this. So look, let's keep moving forward. I want now to introduce you to Dr. Ines Nunes de Cunha and Tagamze Noor. They're going to give us a presentation from FIP on the Hypertension Pharmacy Toolkit, which is a practical tools to support pharmacy practice. So colleagues, over to you.
Thank you so much, Daragh, for the introduction. And I'm feeling so grateful today on the World Heart Day for having the opportunity to present to you our new resource, the FIP Hypertension Pharmacy Toolkit, and to have these excellent speakers with us today. I'm feeling so inspiring and grateful, so thank you so much. So before we dive in the presentation, let's take some time to give you just a brief note because I would like to highlight that the Hypertension Pharmacy Toolkit is designed to support pharmacists in their interaction with patients, but it does not account for specific national regulations. The roles and responsibilities of pharmacists vary across jurisdictions, so users must ensure compliance with relevant national laws and professional codes, including national drug regulations, data privacy, and professional and ethical conduct. I would also like to sincerely thank to the FIP team who supported the development of this toolkit, in particular Gamze Noor, FIP intern, and also to my colleagues from the marketing team for their assistance with the design, and also to my colleague Dalia Badges, FIP head of programs and provision. So, to help us to avoid the barriers and to work on this topic, we have developed the Hypertension Pharmacy Toolkit. This toolkit was being developed to help community pharmacy teams start the hypertension conversation and make their interactions with patients more impactful. The Hypertension Pharmacy Toolkit has also been designed to enhance patient engagement while minimizing the burden on workload and workflow in community pharmacies. And this toolkit supports pharmacy teams in effectively identifying patients at risk, as well as those with uncontrolled hypertension, providing motivational counseling and empowering them to engage in assessment and management. You can access to the Hypertension Pharmacy Toolkit via the FIP NCDs webpage. So you can go to the main NCDs areas, select cardiovascular diseases, and then click on Hypertension Pharmacy Toolkit, or you can scan the QR code that you can see on slides. So the Hypertension Toolkit helps, as I have mentioned before, this toolkit helps community pharmacy teams set up or improve programs for assessing and managing hypertension. It focuses on 4 core elements that support a standardized approach, integrate care into daily pharmacy workflows, and also encourage collaboration with the prescribers. And the first element is the hypertension educational guide. This educational guide gives pharmacists the knowledge and tools they need based on evidence and best practice, like the guidelines that Dr. Ross have mentioned before, to deliver effective hypertension care in real-world settings. The second element is the hypertension assessment tool. This is a conversation-based tool designed for pharmacists and where appropriate also for pharmacy team members to support patient counseling. It helps guide discussions around the disease, risk factors, blood pressure monitoring, and also strategies to prevent or manage the condition more effectively. The third element is the hypertension patient information leaflet. This is a printed handout to be shared by a pharmacy or pharmacy team member with the patient, and is designed to summarize the pharmacist-patient interaction and provide additional information on hypertension, its risk factors, and self-management strategies. And finally, the fourth element is the hypertension primary care referral letter. And this is a personalized letter that can be sent by pharmacists to patients' primary care physician. And it explains why the pharmacy is reaching out and outlines how both professionals can collaborate to support the patient's hypertension management. And I will now hand over to my colleague Gamze, who will give you a more detailed overview of each element within the Hypertension Pharmacy Toolkit, so you can see how they work in practice and how they can be applied in a community pharmacy setting. So Gamze, over to you.
Thank you so much, Ines. We really work hard. We really worked hard, and it's a great opportunity to present the present outcome of our efforts at such a meaningful event in here. And now I will continue with the truth of our toolkit documents in more details. First of all, in our educational guide, this educational guide is a self-study module recommended for all pharmacy staff who will be participating in or supporting the delivery of Hypertension Toolkit program. This guide is designed to enhance pharmacists' knowledge of hypertension and their role in helping patients achieve better health outcomes through their disease journey. And it covers why we should focus on hypertension, the pharmacist's role in care, and provides a clear overview of the condition. It also explores screening and assessment, evidence-based approach to management, and includes a case study demonstrating how to apply Hypertension Toolkit in practice. To consolidate the learning, the model also provides key takeaways and glossary of common terms. And the next slide. Yes. In here, we have a second tool, and it's the hypertension assessment tool. And this tool has two main sections. The first section, risk identification and education, helps pharmacists guide structured conversations with patients who may be at risk of hypertension. It provides a clear risk assessment flow, a checklist of questions and conversation triggers to support patient counseling. And key topics include lifestyle change, early detection, regular monitoring, and guidance on documentation and referral to ensure timely follow-up. And in the second part of the hypertension assessment tool, focus on monitoring and symptom review. It includes key questions about home blood pressure checks, medication adherence, diets, physical activity, and other common symptoms such as headache, dizziness, or blurred vision. These questions helps pharmacists identify potential issues with blood pressure control or treatment adherence. Depending on the sum of the patient's answers, pharmacists can provide guidance on lifestyle change, support with medication adherence, demonstrate correct blood pressure measurement techniques, and refer patients to their doctor if needed. Then we have the assessment tool is designed to streamline patient engagement, allowing hypertension assessment and counseling to be easily integrated into everyday pharmacy practice. It reinforces the pharmacist's role in education, adherence support, and early intervention. Using the tool takes around 10 minutes per patient. It's recommended to offer a private, comfortable space for the conversation. By using this tool, pharmacists can have structured, meaningful conversations that empower patients to better manage their hypertension and reduce the risk of complications. Then we have patient information leaflet. This patient's pharmacist conversation record is a leaflet for patients that summarize the pharmacist patient interactions and provides additional information on hypertension. It allows patients to review key advice about their risk of developing hypertension, the risk of worsening symptoms for those already diagnosed. Designed to support clear counseling, it ensures that key information is not lost, can be reviewed at the patient's convenience or shared with family members. The leaflet includes sections such as what is hypertension, why am I at risk, a symptom checklist with importance of reporting symptoms, and practical lifestyle advice. A pharmacist or appropriate pharmacy team member should complete and share the leaflet during or after the patient assessment. It takes less than 3 minutes to print and should be provided in a private supportive consultation settings. On the slides, you can see the examples of brochures included in patient leaflets, such as lifestyle modification advice, hypertension treatment plan, how to measure blood pressure, and the blood pressure monitoring records. In the next slide, finally, the hypertension primary care referral letter is a personalized letter that pharmacists can send to pharmacist, primary care physician. It explains why the pharmacy is reaching out and how both professionals can collaborate to support the patient's hypertension management. The letter includes an overview of its purpose for the prescriber, patient risk factor, and symptom summary checklist. This checklist of actions taken by the pharmacy, such as lifestyle counseling, blood pressure readings, or researchers shared, and the recommended primary care follow-up checklist. This tool is designed to simplify documentation and referral, enabling the pharmacist to quickly capture relevant information and a recommendation while supporting collaboration with prescribers. It takes also less than 5 minutes to complete and can be shared either in print or electronically. Then, in summary, this toolkit will help you recognize and identify patients at risk of hypertension, those showing hypertension symptoms, or patients who are already diagnosed but not well controlled. It also supports you in starting meaningful conversation, taking appropriate actions, and collaborating effectively with primary care. So thank you so much, I will continue with the Inês presentation. Thank you so much.
Thank you, Gamze. So, to support pharmacists in using the Pharmacy Toolkit, two complementary resources have been developed to provide both quick reference and a practical learning guide. So you can see on this slide that we have developed an hypertension infographic. This is a one-page digital visual aid providing a quick reference on when, where, and why to use the Hypertension Pharmacy Toolkit in practice. It also includes direct links to all these resources that we have showed to you. We also have one CPD Byte, and the CPD Byte is a short video that provides an overview of hypertension, including its global burden, risk factors, and links to other chronic diseases. It highlights how pharmacists can support people at risk or living with hypertension, and also, of course, introduce the Hypertension Pharmacy Toolkit. And together, these two resources make the toolkit more accessible, helping pharmacists quickly understand and apply its content in practice. In conclusion, we as pharmacists and as accessible primary healthcare providers, we are ideal positioned to support the prevention, early detection, and also long-term management of hypertension, building on pharmacists' established role in cardiovascular risk factor management. And there are multiple opportunities, as we have listened during the webinar, within the pharmacy to identify at-risk individuals, monitor blood pressure, and provide timely counseling, tailored lifestyle advice, and also referral to the doctor when necessary. So, through education, regular monitoring, and collaboration with prescribers, pharmacists can play a vital role in reducing hypertension-related complications and supporting healthier communities. To support pharmacists in further cardiovascular care, FIP publications also include the Cardiovascular Diseases Handbook for Pharmacists and the Cardiovascular Diseases Knowledge and Skills Guides. And these resources outline the knowledge and also the skills needed to deliver effective services and complement the Hypertension Pharmacy Toolkit. And both publications are available on the NCD's, on the FIP NCD's webpage. And I hope you find these resources useful in your practice, and thank you very much for listening.
I want to sincerely thank my colleagues from FIP for a brilliant presentation there. The amount of content that's in the toolkit is amazing, and I know it is difficult to do full justice to it when you want to give a presentation, but I know that colleagues will take from it as a taster to be able to say that they know where the resources are and the resources exist. Colleagues, I want to thank you for the very, very complimentary feedback that we're getting in the chat box. I know that people are getting an awful lot from this. It's great to get that response from people, because sometimes we feel that the enthusiasm we have, it's hard to know if it's being shared by people who are joining us on the webinars, but certainly the feedback is overwhelmingly positive. So I thank you for your positive contributions to that. We have some minutes left, and I see that there are some questions which are unanswered, but the majority of the questions are answered. So thank you for our participants for answering those questions. What I would like to do, maybe just by getting everything started, would be to put the first question to you for me, just to get the ball rolling, and then people can join in after. Inesh, you very kindly shared the toolkit with us, which is for cardiovascular disease. Because we have a minute, are there any other toolkits available from FIP, maybe around non-communicable diseases, that you could highlight for us?
Thank you so much, Daragh, for the question. And the answer is a big yes. Yes, in addition to the Hypertension Pharmacy Toolkit, there are 4 more toolkits available on the NCD's webpage. And these toolkits include the Chronic Disease Services Initiation Toolkit, that is a toolkit designed to motivate and support community pharmacy teams in establishing or enhancing a community-based chronic disease screening and management program. So I advise you, if you want to start a program in your pharmacy, start with this one, because this is the general toolkit for all chronic disease in general. And then we have also the chronic kidney disease pharmacy toolkit. We have another one related to cardiovascular diseases, that is the heart failure pharmacy toolkit. And also we have the chronic obstructive pulmonary disease, COPD, pharmacy toolkit. And all of these resources aim to support colleagues in preventing, identifying, and managing key non-communicable diseases. And I invite you to go to the webpage, the NCD's webpage, and I will share the links after. But feel free to go and to download these useful materials. So thank you for the question, Daragh.
Yeah, and look, that answers a question that's come through from Priscilla, who asked the same question on the Q&A. Access to all of this is available to you through the FIP website. And again, I'll take the opportunity to encourage people to become FIP members. This stuff doesn't get done on its own, and it gets done because we're a federation of members and member organizations, and that's how we get the work done. The enthusiasm that people have for joining in a webinar like today, we want more people like that to become members of FIP so we can drive on really good pharmaceutical care around the world. If I may, Nesrul, I have a question for you that's come through, and I really like it. It's a clever question. How do we ensure consistency and quality in pharmacist-led hypertension detection and preventative service across different practice settings? So I'd be delighted if you could talk to that just for a moment, please.
Thank you for the question, Dr. Daragh. Yes, as you said, consistency and quality should be achieved, and this can be achieved by following standardized protocols for blood pressure measurement and referrals. Also, regular training and certification I think it's very important for these activities. Collaboration with physicians and use of digital tools such as electronic health records, also some other tools. I think these will strengthen continuity of care.
Brilliant, brilliant. And then maybe, Andrea, if I could come to you, we really enjoyed the patient-focused outlook that you bring from the World Heart Federation. If we were to take it maybe as a practitioner-focused question, what are the roadblocks that you have seen practitioners overcoming to be able to deliver better care to people who are living with cardiovascular disease?
Well, I think it's also the not being adequately prepared, not having sort of rehearsed that role, or realizing that we should be digging in to see not only prescribing and making sure that people are getting their medication in hand, but are they really taking it? Are they I think the toolkit, which I sent to one of the respondents, is really showing you that just a few questions to ask, to read them through, to be familiar, and to test, because I think we need to really engage more with the community and invite feedback on adherence. That's, I think, the most important thing that HCPs can do.
That's fantastic. Ross, one of the things a question that I would like to direct to you is that around the world, we see that there are places where pharmacists are more engaged and more integrated in delivering really good care at what I might say is sometimes misunderstood as the lowest point of complexity within a healthcare system, which is at the counter in a pharmacy. The journey started somewhere in Canada. Can you share a little bit with us about how you got pharmacy in Canada to where it is, for the excellent work that you're doing for people's cardiovascular health?
Well, how long do you have? Yeah,
We've got 7
it is.
minutes.
No, it's definitely a journey. I mean, we were doing work on this back in the early 90s, which showed under usage of evidence-based therapies across the board in cardiovascular medicine. And I had this idea that maybe pharmacists could help, but our pharmacy practice in the province of Alberta was about the most backwards I've ever seen. And so I didn't hold out much hope for it, but it's amazing how things can change. And I think it's just, you need to realize that every journey starts with the first step. And so we started out by just measuring, being systematic, little steps we took in the beginning when we couldn't prescribe. We could still, the magic of it is still the assessment. It's not, the prescribing is just one of the tools. Um, and so anybody can do an assessment, right? And so what we did is we took the Canadian guidelines and said, well, we don't need to reinvent that wheel. It already says what should be assessed. So it's a matter of creating tools around it and do a good assessment, and then use the tools that you have available to you. And so if that means referral to a physician, then fine. You got to start somewhere. And I think the approach that we took is we designed studies around that so that we could prove that at least this first step really works very well. And then as we were able to do more and more, we just took it that much further. And so we're at the stage right now where we've already proven that this works. There's no question that it works. It's how do we implement it more widely? So we're sort of at that stage right now. But I mean, it's taken 20 years to do that. And as I said, it all starts with the first step, and it's having the courage and the wherewithal to say, okay, this is difficult, but let's take a first step. And so I think what I would encourage everybody to do is the lowest common denominators, we can all measure and assess blood pressure. And so in terms of bang for the buck, I would say that's the place to do it. And if anyone is interested, I think I put in the chat that May Measurement Month in Canada, I'm the chair of the Canadian contingent for that. And so I said, well, we would only participate if we could use pharmacies for the blood pressure screening. And so we're one of 2 countries that use pharmacies as the main venue for screening. And again, you could look at that as that first step that you take. And if there's any interest in forming a worldwide coalition of pharmacies interested in May Measurement Month, well then, we could do that. And I can share some of our learnings from that.
Well, I think it goes without saying, Ross, that you have found an able and willing cohort of pharmacists and pharmaceutical scientists here today, and I think it's a brilliant place to start. So the one thing that you're saying our call to action should be get out there and start measuring.
Absolutely.
Okay. I'm going to direct that same question then to Andrea. Andrea, what's your one thing? What's your one call to action to the pharmacists, pharmacy scientists, pharmacy educators who are with us today on the call?
Yeah, to really take full consciousness of their really crucial role in the health journey of those who are consulting them. We know from the global burden of disease data, we've gone from infectious disease, where infectious disease was really our biggest challenge. Now it's chronic disease. You see people living longer, but often they live more years with health challenges. And we want to address that. So I think we've got to wrap our arms around chronic disease. And I think one of the best ways to do that is to address adherence.
Brilliant. Thank you very much. Professor Nesugul, can I ask you that one call to action from your input, please?
Yeah, Dr. Daragh. I think today's discussion clearly highlights the crucial role of pharmacists in hypertension management, but not only in only management, but also in prevention and detection. I think these new tools will be very helpful for detecting hypertension. Detecting early and early management of hypertension also.
Brilliant, brilliant. Colleagues, we just have a couple of minutes left. Part of my screen is telling me that I have to do a wrap up and a conclusion, but I don't need to because our three brilliant contributors have just done that. And also the fact that there's been such a fantastic highlight of the toolkit, which is available to everybody, has been highlighted by Gamza and Inesh. It's fantastic. Look, just a couple of things to say. Please stay involved with FIP. Please look at becoming a member if you're not one already, but also to know that there is a family of pharmacists out there, and we meet globally once a year. And I'm delighted to say that our next meeting for a World Congress is going to be in 2026, and it'll be our 84th, and it's going to be in Montreal in Canada, in Ross's home country. So you're all more than welcome to attend that. So put it into your diary and have it as something that you can do. It really is the Olympics for pharmacy, but it's also part of a pharmacy family. If some of the research that you're involved in, or you want to know more about research, particularly around the topic that we were talking about today, that we have the sub-theme of integrated health, a second sub-theme of innovating with purpose, and this third sub-theme of collaborating with equity. And there are important dates within that then for abstract submissions. The review of the outcomes will be communicated, then there'll be early registration fees deadline and a second registration. It's who we are and what we do as pharmacists, as pharmaceutical educators and pharmaceutical scientists. So I would be really, really excited to see more and more people joining within that family at the World Congress. Everybody, sincerely from everybody at FIP, I want to thank our contributors today. They were truly amazing, and thank you for your